everyone. Without further delay, we're just going to start just to allow more time for our presenters. So I'm just going to introduce Dr. Fouad. Fouad is an associate professor of public health practices at the Faculty of Health Sciences at the American University of Beirut. He's also the IDRC chair for the Forced Displacement Program in the Middle East. He's also the co-director for the Refugee Health Program at the Global Health Institute and a research fellow at the Issam Paris Institute for Public Policy and International Affairs. He has extensive research on migration and health, focusing on multidisciplinary approaches to forced displacement, health systems in humanitarian settings, and the political economy of health in protracted crises. I'm just going to also introduce Dr. Rouham Yamout. Dr. Yamout is a research associate at the Epidemiology and Population Health Department at AUB. She's also the project coordinator for the Rebuild for Resilience. Dr. Rouham Yamout was a medical doctor for almost 20 years before moving into public health, where she now focuses on health system research and strengthening access to quality healthcare. So our presenters today are, the webinar is entitled Claiming Local Decision Space, the Municipality Health Committee in Majdal, Anjar. So without further ado, welcome.
Thank you very much. Thanks a lot for the introduction, and thank you for coming, and also for those who are online now. So this presentation is part 2 of the presentation that we did maybe a few weeks ago as a part of Rebuild for Resilience, or R4R project, which is a FCDO UK funded project on strengthening health system resilience in fragile settings. The 4 settings for that project are Lebanon, Sierra Leone, Nepal, and Myanmar. So today we'll present on the issue of one of the 2 initiatives that we already started. Last time we introduced the CTC, or community, close to community initiatives, and today we'll present the other initiative, which is called Learning Site. So we will go with sort of background about Learning Site and the whole project and Learning Site, then methodology that we used, which is participatory approach research, mapping of the Learning Site, and the initiative, municipality, what we achieved, the challenge, and the way forward. So again, we will go with this. I think that last time we presented, but just to sort of a reminder about the project itself.
Introducing Rebuild for Resilience. What are fragility and shock? 1.8 billion people live in fragile settings, with that figure expected to rise to 2.2 billion by 2030. Settings are fragile due to diverse stressors and shocks. These include political unrest, conflict and violence, economic or social crises, natural disasters, and climate change. Real-world problems. In fragile and shock-prone settings such as Sierra Leone and Nepal, there are health systems that face severe resource constraints. Events such as earthquakes and epidemics give rise to additional health and support needs. Vital deliveries may not be possible due to travel restrictions, or health workers themselves may be displaced, meaning the delivery of critical services and treatments may be interrupted. How systems respond to shock. When a health system is affected by shock, the response likely falls into one of 3 categories: collapse, maladaptive or short-term responses, which may cause longer-term problems, or positive or resilient responses. A resilient response, like at this clinic in Myanmar, can encompass absorption, accommodating needs within existing resources, such as working longer hours; adaptation, accommodating needs by changing the way the current system works; and transformation, changing the system permanently in response to the shock, like enabling community health workers to deliver health education sessions in remote areas. What do resilient responses depend on? In Rebuild for Resilience, we think that resilient responses relate to specific dynamics and interactions, such as the link between routine and emergency planning, what resources are available and how resources are used. The dynamics of social networks and how data and information is shared and used for decision-making, and the ability of health systems to learn from previous experiences and remain accountable to their populations. What is Rebuild for Resilience studying? In Rebuild for Resilience, we study how health systems respond to shocks and stressors. We work to identify the strategies and capacities that strengthen a health system, making it more resilient to shocks, and enable the delivery of gender-equitable, high-quality healthcare for all. Find out more about Rebuild for Resilience by visiting rebuildconsortium.com.
Thank you, Samira. So I forgot to introduce the Lebanon team, Rouham Yamout, Joanna Khalil, and Samira Abdullah. Sorry. and Youssef, who's our local coordinator in Majdal Anjar. He's not here. Youssef Abdul Khaliq. He's from the local committee in Majdal Anjar. So as I mentioned, one of the the two initiatives for this project is the learning site, and the approach is a participatory approach research. So when we start thinking about how to select the learning site in Lebanon, the main issue that we thought about that to have like a diversity in population, because this is a major shock in Lebanon about the issue of migration, displacement, and the vulnerable population. The second one is to have a sort of infrastructure to build on and have multiple stakeholders. And after exploring several learning sites, municipality, we decided to have at the beginning, two learning sites in Bar Ilyas and Majdal Anjar. And both actually have like a different vulnerable communities, including rural Lebanese, Syrian refugees, and Palestinian refugees, and have like many stakeholders, including facilities affiliated with Ministry of Health, international organization, local organization, and also main issue that's clear in Beqa Valley, it's the informal health sector. Anyway, by time, Bar Ilyas didn't show a sort of strong commitment on being, part of these initiatives, and ended up that we focus on Majdal Anjar, which has like a sort of almost 50-50, maybe more Syrian refugees than the Lebanese. And just recently, after we finished the first cycle that I will show, recently we selected another municipality called Al Manara. This is the second one here. Here it's like a Bar Ilyas and Majdal Anjar, but I think Manara will be down. So to start the second learning site, or to expand the concept of learning sites. Next. So we did mapping, and Rouham will do that in both Bar Ilyas and Majdal Anjar, because actually even in Bar Ilyas they didn't show commitment, but still people in Majdal Anjar using also the facilities in Bar Ilyas. So in addition to hospital dispensaries, in both, so we have a considerable number of international and local organizations that are working there. So these are, after the mapping, what we did, these are the services that are provided there. And, as I mentioned, the number of facilities, the issue of source of funding, mainly from Ministry of Health, international organization, and local INGOs. And there are like a variety of services provided by different health providers. Next. So this is the framework of what we called it participatory approach research cycle that started for each learning site with mapping the current situation, using review of document and a key informant interview with the local stakeholders, then moving to identification of leverage points and co-developing intervention with the local community, using the group model building as a sort of methodology, and then start implementing, the innovative initiatives, then going after the implementation to reflect on the process and documenting the activities with doing reflective meetings and another round of exit key informant interviews, adapt accordingly to the results of this cycle, and then go to another cycle of doing the mapping. In the first learning site, Majdal Anjar, we finished the entire cycle now, and we will start a second cycle. But at the same time, we will move to Manara as a second learning site using the same framework, but we will have I think Rouham will mention that we will have in this cycle the member of the municipality health committee as a sort of partners with us, a sort of lesson learned from them to go with us for the second cycle. Next. So Rouham will continue with the results and the recommendation.
Thank you.
Is it okay like that? Yeah, okay. So let us start with the methodology and what data are we used to present this for you. And let me mention that it is just an introduction to this work. This work has a lot of more findings and nuances that we don't have the time to say all. So the first, we did a literature review, reviewing 65 documents. It was a scoping review. We had something like 17 key informant interviews, 9 at the beginning of the learning site project, and 8 as exit interviews. All those are local stakeholders. We have our observations and site conversations. We all document in a field journal, and we are using this material also to feed our research. The reflective meetings and workshop reports. We have the actual strategic plan and the actual TOR and bylaws of the Municipal Health Committee. We also document all WhatsApp group chats to understand the content of conversations between members and ourselves. And we are using quantitative data and surveys. And we're analyzing all this through identifying different patterns and insights around the corresponding themes. So we are doing thematic analysis of all this material. So the main findings of the first phase, we are developing a paper called Navigating Turbulence, Analyzing the Resilience of Lebanon's Healthcare System in Multi-Crisis Scenario. So the main finding that we came to, we have in Lebanon in general, and all this is reflected at the local level, governance challenges, because MOPH has compromised function in organizing and controlling healthcare delivery. UNHCR is trying to replace, but so far the replacement is not complete and is not sufficient. As a result, we have a health system landscape that have a reinforcement of profit-oriented delivery of healthcare services and more donor-driven agenda and more influence of powerful lobby groups. For partnerships and collaboration, we know that MOPH disengaged financially and also logistically from controlling. Therefore, MOPH lost its incentivizing power. So hospitals don't care anymore, remain accredited or lose accreditation, and the same thing about health centers. We have increased fragmentation and privatization because more and more people go to the humanitarian business. And we created something that is inequities within the system. Now we have health centers that are supported by IMC that are at privileged positions and health centers that are not supported by IMC. So we had new layers of inequities. About availability and use of resources, as everybody knows, we have a professional shortage, especially nurses, especially registered nurses, scarcity in medical commodities and maldistribution of medical commodities. And we are seeing more and more increased gap in access to healthcare services, and we are witnessing new layers of inequities. The country, but so a lot of resilience measures, but here we will mention only 4. First of all, MOPH implemented adaptive measures. MOPH did like policy shifts, created new policies, allowing health centers to collaborate and be supported by other than MOPH funders. Humanitarian actors also increased appeal. A lot of money is coming to Lebanon. How it is distributed it's another problem, but a lot of money is coming to Lebanon, and UNHCR and all the INGOs that were previously focused on Syrian refugees now extended their help and support to the vulnerable Lebanese. We saw the flourishing of the emergence, not more than emergence, okay? They are all over the place, of the informal sector, an informal sector that was not recognized by MOPH at all. And now this informal sector is hosting something like 50% of its clientele is from Lebanese population. Before it was just 8 or 10%. And we are seeing this informal sector more and more enjoying tolerance on the part of MOPH and on the part of the local authorities like municipalities that are facilitating its work. And we saw also the emergence of a version of a new way of doing that are municipalities who were very much active during COVID-19, who held the country within their crisis cell, and that showed that they can be the real hosts of health governance. So how the Municipal Health Committee has taken birth. We were sent to this place to increase or improve the resilience of local health system. So we went there, and basically we didn't find a local health system. We don't have something that is called local health system. Okay, we have a district office of MOPH, but this district office is neutralized. We didn't understand what is the function of this district office. Although we approached the district office, but we didn't reach anywhere. So, طبيب القضاء, طبيب الأداء. Yes. Yeah, but it is an inefficient structure for some reason. Okay, we will know. So we use the easy way of doing it. We went to a lower structure. We said, okay, let us go to municipality. And this is how it worked. We invited municipality as local stakeholders, and we sat in this group model building. And there they said in the group model building that our problem is that we are lacking a governance structure that is regulating healthcare provision. And this is how the final decision was, in a participatory approach, was to create a municipal health committee. This municipal health committee was thought at the beginning as they have something that is called medical committee in every municipality. And this medical committee, what they do, that they facilitate subsidy of MOPH and etc., and charity, and raise funds for someone who needs hospitalization, etc. So this idea has evolved little by little to become, okay, we want to govern healthcare and to regulate financing, to control quality, etc., etc. Like here, an anecdote. He said, "Who will be doing this? Who, if we want to now govern healthcare, like we are saying?" The mayor was telling, "Who will be facilitating for those people to go to hospitals?" And my answer was, nobody will need this anymore. If you are really regulating healthcare, if you are administering it, well, nobody will need to call you to tell you, please make me a wasta because I want to go to the hospital. Okay? So, who are the Majdal Anjar Municipal Health Committee members? We have three categories of members. First, we have the members that are coming from the municipality board and that are not persistently, but coming from time to time to the Municipal Health Committee and consider themselves as members. We have local health professionals and technical people. Some of them came by themselves. They say, I want to join this committee. And the others were just sent by the political members. Okay, go to the health committee. And we have the members of our learning site. When we started also, we gathered people, and we came with those people to the Municipal Health Committee. This is the composition of the Majdal Anjar Municipal Health Committee by gender. We have men and women. We have Lebanese, and for the first time, we have Syrians that are members of the Municipal Health Committee, and even a Syrian doctor who is part of the informal health sector is the vice president of this committee. And we have one Palestinian nurse who is also with us. We have 2 doctors, 5 nurses, 2 NGO workers, 1 pharmacist, and 5 that are non-medical profession. Okay, they have businesses, basically. And we have 7 people young, under 40. Also now, young is under 70, as everybody knows, but and 8 that are 40 and plus. So what did we achieve to date? And here I will not go into details to not annoy you. But the first thing we did is we established this as a structure, as an institution. What does it mean? We defined memberships, and we had a strong affiliation with municipality. Whatever this committee is doing is backed by the municipality. That is an elected body. I want to remind everybody because we forget sometimes. It has a legal status. Yani they didn't do it, but they started to do it. They want كتاب من وزارة الداخلية to legalize this entity. We have written towards and bylaws of this committee, and we have a strategic plan that is written that has vision, mission, values, whatever is needed in any strategic plan. They are developing an emergency plan. It's not finished, but they are on the good path. And they started a centralized database. Okay? And all their activities are going into 4 directions. The first one, they are doing population health activities targeted to the population. They are gathering data because they are committed to evidence-based local governance. They are partnering with health institutions around, with hospitals, health centers, whoever is engaged in healthcare, and they are undergoing capacity building. Next, in a little bit in more, there is one that we skipped. Voilà, okay. Those are a little bit in more details. I will give you examples for the population health plans. Joanna wants to do a seminar only for to describe those activities, and I think it is a good idea. For example, we have school health, virtual blood bank, accelerated vaccination activities, access to chronic medication, population-wide awareness, breastfeeding, nutrition, safe child environment, etc.
Done by the committee select medications that that are not used by people, and they have sort of categorization medications to put under the supervision of the to great job because they was able to provide remedy chronic diseases. And the other one is the virtual blood bank. So they have a database now in the Anjar on their blood group and
potential donors.
It's easy for that to contact people for donation. One of for me one of the great.
Okay, it is worth it. Exactly, this is I wanted to say. Okay, all those plans, and you will see they are called plans. We don't call them program, we don't call them projects, we call them plans because they have the vocation of integrating the work of the Municipal Health Committee forever. For example, school health, every year they will be doing it, okay? It is something that is becoming their routine. This is why they are called plans and not projects that can take end. And the second vocation they have is to address everybody in Majdal Anjar, all the dwellers, not only Syrian and Lebanese, but also rich and poor, young and old, women and men, everybody. This we don't have a target population. We are not doing like INGO. We are targeting 100. We are targeting 200 here. We are not doing this. Everything we are targeting everybody. If we are doing school health, we are targeting all schools, not only public schools, not only private schools, but all schools. And this is a new approach, and this gives the universality of this entity. The second thing, it is collaboration and community engagement. Here, they are doing agreements and MOU with health centers to exchange data and to unify the approach and to control healthcare. And they are disseminating events and being active on social media to recruit the community and to mobilize the community around this idea. Capacity building, they are already undergoing and will still undergo different trainings on different technical aspects, on the concepts of the resilience framework, on gender, equity, justice, what does it mean, different technical trainings on a lot of topics, on the strategic and emergency planning, and on data management and analysis. They didn't go it yet, but it will come, okay? And at the end, the data plan that aims at the end to establish a comprehensive database capable of tracking population health data and service delivery data and match them together. Now, we are dreaming a little bit, but okay. What challenges? What challenges did we observe? The first challenges is in the governance culture, in the country in general, and whatever we find in the ministry, we are finding in the municipality, we are finding everywhere, okay? So this is the power relationships into those committees that we need to change, to shift from improvisation, clientelism, personal interest, power seeking, towards collective work committed to evidence and to public welfare. And this is very difficult. This is the main difficulty we are facing. We had two categories of members so far. We have the political members who are here explicitly expecting personal benefits. Before they were not talking, now they are voicing this. They are expecting something for themselves, or power, or influence, or networking, or money. Okay, it is different. Every person has own expectations. And they are starting to hinder the healthy evolution of the Municipal Health Committee towards what we wanted them to be. Okay, they are like neutralizing our efforts. But we got another group that we are calling them the technical members. Okay, they are not very much technical, but this is what they are aspirate to be. They are demonstrating authentic dedication. And like Joanna was saying, they are starting to use those wording of accountability, transparency, commitment, etc. And they are operating as a cohesive team together, and they are fostering progress and synergy. So we have other challenges concerning ownership. Some members are still see themselves as passive recipients, not as actors, okay? And we understand that we need more work to align the understanding of all those concepts. Okay, they understand by transparency something else that we understand. They understand by accountability something else that we understand. So we are working on aligning all this. Legitimacy, we have problems of legitimacy. All people, UN, INGOs, MOPH, nobody shares data. They don't share data. Data concerning the village, they don't share with the municipality. And they are right in doing this. They tell you, we cannot share data. It's confidential. Okay? And the second problem in legitimacy, the population in general doesn't trust municipality. Not the committee per se, but the municipality in general, nobody trusts the municipality. So here we need work too. About accountability, so far, the members of the Municipal Health Committee tend to prioritize process over outcome. When they talk about the things we are doing, the activities, they talk about the process. They don't see the outcome, okay? And some of them still engage in undisclosed deals. For example, one of our members received a big box of medications from Mukhtarib, someone, for the village. He took the box to his house. And we told, why did you do that? Why didn't give us the box? He said, but he maybe use it for the next elections, okay? He might need those medication to win the elections. So they are still thinking like that. And still they have data accountability gap. They throw at you numbers sometimes. Nobody knows from where these numbers come. So far, we don't know how much people live in Majdal Anjar, exactly. We had different members, from 40 to 70,000, from, it is, people do not observe the rigor in telling numbers. Okay, I am almost done, okay? So what we are doing to resolve those issues? First, we are really committed to this, and we know that we believe that this will work. Okay, we will give it the needed effort to work. So what we did, first of all, we did that we appointed an embodied researcher, Fouad was mentioning, Youssef, who will be continuously collecting data and who will be overseeing the work of the Municipal Health Committee, will be guiding them, who will be make sure that they have the ownership of it, they are working in a cohesive manner, in rigor, and in accordance with all the scientific requirements, okay? We are conducting evaluation and self-evaluation discussion meetings to boost the feeling of accountability with Municipal Health Committee members. We did something that is, I think this will save us. The mayor, it is the proposal of the mayor, will hinder the interference of political members. Okay, he will forbid those members from the municipal board to come to the municipal health committee and to start imposing their rules and their interests. Okay, so we will have we will keep on working with this technical group, with those people who already understood this concept and are already in the good way to reach this outcome. And we want, at the external, we are advocating for the redirection of support from solely, merely supporting services to supporting structures. We need all, part of those resources, human and financial and everything, that are put into this village, to go into the support of this municipal committee, to reinforce it, to enforce its legitimacy, and to claim the space to make decisions concerning healthcare. Next. Like Fouad mentioned, now we are scaling up this, and we started to the learning site too in Al Manara municipality. Why did we choose Al Manara? Because it is near Majdal Anjar, and they can benefit from the same networking, and they can help each other. And those who are in Majdal Anjar can help those who are starting this journey in Al Manara. What are the differences with Majdal Anjar? First, the mayor is a doctor. He is a health professional. So, like, he understood us much better from the first time, okay? They have lower population, much more controllable, yet it is diversified. They have and Syrian and Lebanese and Palestinian. And among Lebanese, they have two confessions. They have Druze and Sunni. And the third thing, it is under another district. Okay, it is nearby, but it is another district. And the district physician of the West Bekaa, West Bekaa, is, hopefully, he will end up to be more responsive and more collaborative. And it is a good opportunity to also try to scale up to the district office and like recruit the district office into this work. And we want to go there applying two main lessons, a lot of lessons learned from Majdal Anjar, but two main lessons learned from Majdal Anjar. We will recruit an embodied researcher from the beginning to coordinate the efforts and to guarantee cohesiveness of the group and rigor and efficacy, effectiveness. And we will protect the health committee from political interference from the beginning. Okay, we will not go into this phase of, okay, accepting everybody and letting people come and do whatever they want in the committee. So here are the questions for you all and the ideas about. emerging from this presentation. The question, first, can evidence-based governance overcome politics? Is it possible? Can we do it? And how do you think we can do it? To what extent can the work of researchers reshape prevailing practices, mindsets, and beliefs? People are used to use power in this way. How can research change this? What more can be done to propel Municipal Health Committee further towards its goal? How to establish and wider and higher legitimacy of the model. Yani, the peers to understand this model and to comply to it, and the Ministry of Public Health, how to trigger that the Ministry of Public Health recognizes this model and capitalizes on it. Okay. And that is all. Thank you very much. Waiting for your questions.
So, few questions, but just one issue that sort of lesson learned, after 24 months. The main challenge that we faced is the issue of ownership, and I think also our achievement went in that direction. Who own these initiatives? And at the beginning, the people's expectation, the local community expectation that AUB or those international funding agency will help people to have I don't know, improve their health and putting strategies for them and so on. Our goal is to do actually in the other direction, is that they should own this initiative and start building, their own strategies. And that's why we started immediately, after having, the group model initiative, that to have a strategic plan. They put their own strategic plan. But then even after strategic plan, they have strategic plan, they also start asking who will implement that and how we help in doing this, or either secure money or sort of, helping them in doing survey and so on. So that was the main challenge about the issue of ownership. And a lot of troubles, to be honest, happened, because of, what's our role as AUB and project management, and what's their role as a sort of local community. And I guess we have a start, at least in the last few months, to see that they have more and more that feeling of ownership. Maybe in the next cycle, and especially moving also to the second learning side, is to have that sort of feeling that they, this could actually, protect the issue of sustainability in the future. So, this is the main issue. Otherwise, all the other technical approach went to some extent well. But our concern is about the sustainability after the end of this project. I'll stop here and thank you very much.
Thank you, Dr. Fouad and Dr. Yamout, for sharing with us the lessons learned from your experience at Majdal Anjar. I think I'm just going to open the floor for questions. And now, okay, let me start.
Thank you very much for this very interesting presentation. I think the meaning of what you are doing doesn't extend only to Majdal Anjar and Manara or something, but it really extends to Lebanon, and I think to all municipalities in Lebanon, which makes it much more complicated. My comment has to do with two operational things that I was not clear was available. The first, when you looked at your membership, there was no public health person. There were physicians, nurses. Even if there is no public health person in the village, one has to think of one of you or bringing in, I think public health is the field that can lead this project, and its absence starts on a wrong footing. So I don't know whether you thought about public health people.
No, actually, we have one who is the vice president and also AUB graduate, Dr. Fadi Halabi. Is a doctor and also MPH student. I mean, he finished his so Fadi Halabi is the public health. But I do agree, we need to have this concept. That's what we and Muhammad also.
But
So
perhaps in my mind, in the leadership. Because
well, this is the committee, I guess. You know, this is the committee. This is
yeah,
the
but
leadership
the
structure.
committee, yani,
Maybe anyway. So we'll think about it.
worry is that if you don't think about this as a public health problem, as a public health, and then the membership could choose any direction of the committee. I mean, and this is public health. My second operational question came to me about the secretariat. I mean, so this is a committee, but it cannot put a lot of time, and there must be some sort of secretariat that goes along, a technical secretariat. And there may be MPH residents. I mean, somebody from the MPH class can be a resident there, or two people, because it's very difficult to operate without having, so the administration, in a sense, the model field and the people who are going to work on the ground could strengthen this. I mean, that's what it seemed to me.
To be the leader, to be the coordinator, to be the operational person. And
This is the researcher. That
I mean,
researcher.
he's not a researcher, local researcher. He's actually more. In learning side too, we will have this secretary, because that's what we, you know, I mean, that's the lesson learned. We discovered that we are taking this actually role, which is we don't need to do. So and definitely this is an important issue to have, you know, a secretary position, you know, more than just a committee, which is
My plea is not to call them researchers, but to possibly call them public health people. I mean, the field needs to be portrayed in that. Okay. Medical research. Maybe you can influence the grant.
that's a grant driven.
mayor saying, okay, when this project finishes, I will appoint you. I will appoint you to become the chief of this. So I don't know if it is promised in it, but this idea is coming, okay, that the municipality, ultimately, the municipality will finance, will make it. This is.
I think the questions about scaling up is quite important. It'd be interesting for me certainly to understand what made Majdal Anjar accept what Barrelias refused. And what were those things that made Barrelias close up? And also how far have you gone so far in establishing, at least informing the concerned levels in the Ministry of Public Health and in the Directorate of Municipalities about what's happening? Zero.
Yeah, I mean, the issue is, Joanna will answer the issue of why Barrelias and what happened with Barrelias, and I will answer the second part about the scaling up to central level.
Barrelias, basically, the municipality was the same, because they found that they are hiding medication, and actually it was really very risky, because we had one of the members who was shot, and the level of corruption was really very high. So we're talking about this because we are colleagues at AUB. So yeah, they had to dissolve it. They tried to make a committee, the municipality. Yeah, and they tried to create like a committee to take over the municipality, and maybe we thought we will work with a committee there, but it never, it was never achieved because, of course, there are interferences, and everyone wants to be part of the committee. And the main problem is that the mayor is also the director of a main dispensary in Barillies, so it was all over the place, the linkage between affiliated dispensaries and the municipality. So we couldn't, there was no structure to start with. So we also, that's why we really dropped.
It is reality with family, two families are conflicting with each other, and it is endless. Cannot afford going into this.
So,
Security issues.
so there's really a lot of politics, you know, in this, the entire process, and it's not surprise. Actually, we think that politics should play a role, but not in the negative concept. The issue of scaling up, I mean, this is the ultimate goal of the entire project, is to do something on the local community, but to be able to show it, to present it as a sort of a model. And we know that this will be a huge challenging. We tried in the last 24 months to engage, you know, Ministry of Public Health more and more, but for many reasons, you know, it seems that they are, or they weren't enough interested about that. We hope, you know, by bringing, you know, more maybe good results on this to show it, to present it, but that could be, I think, the next challenge for us. And I agree with Huda. It's difficult just to go from one municipality to another. Well, we can do 2, 3, 4, 5 municipalities, but it's not enough. We need to go on that central level. Yeah.
But I guess if it works,
So maybe
if it works in the challenging places, then it could be easier to apply
Yeah,
somewhere
yeah.
else. Okay, we'll take one more question.
Okay, again, thank you. This is part 2, excellent presentation. Thank you. And it's an amazing project. So I think keep going and documenting, because this is a more or less a unique example. We've worked, the faculty, through different teams and departments and others. We've worked with many municipalities over the years. And I've spent, and many faculty members spent lots of time at Zawt al-Shar'i. It was another experience again. I spent weeks going around the south until we decided to go to Zawt al-Shar'i. And what made the difference is the mayor. A mayor who listened versus mayors who were not even listening to us. And the municipal council, and then we went to Bibnin. It was an IDRC project. The Zawtar was an FHS commitment. And then Faisal Qaq went to Marij, and then, so there are other examples. So I think we had this conversation. I think it will be interesting to sort of to collate these experiences. Although yours are fresh and documented, ours are going to be affected by recall bias, really big time, and we did not document as well. So a big lesson for all of us is the documentation of how to do that with the different communities. The big issue is the ownership. It has always been the ownership. In Bibnin, we went in, we had a great municipal council on our side, the mayor and the vice mayor, and then Rafiq al-Hariri was assassinated. The mayor had a heart attack within a month, he died. And then we had to start all over again. From sadness. That's what everybody believes. And then a new mayor came in, and the relationship had to start all over again. And so it's families, it's political groups, and it's interests. So the ownership is a big deal. And I think in Bibnin we did not succeed in creating that continuity. We have built actually a water disinfection unit. We have built it, we put the machine, and we supplied it for 12 months. All what they had to do was to change the cartridge once a month. And they didn't. We had to go and do it ourselves. They wouldn't. And then when we left, everything, we trained them on GIS, and we did a GIS map of the whole village, every single household. They did not use it. They refuse to be part with the collecting of data. They refuse to be part of looking at the information. So, so ownership is a big issue, and this whole question of how do we make sure that a community transforms into self-ruling and self-governing community. So I think we need to do that. One
Yeah,
thing
actually-
related to Huda's comment about the public health approach is, did the H in the health, the H, connect to environment and social determinants, or is it standing on its own as health problems and chronic diseases and others? So are you looking at the environment? Are you looking at...
Joanna will answer.
Health, it's wider, because we invited Dr. Nasser Yassin also to be because he is from Majdal Anjar. So كان هو الراعي الرسمي لل dissemination events. We did 2 dissemination events. Okay. So we are surely working on waste management, because they are working with Action Against Hunger, with the distribution of bins, and also the water supply, because in Bekaa also we have a problem. So yes, health is not only medical, it's a wider. And we have a cultural committee, so we can collaborate with them. Regarding the issue before, so there's one sentence you mentioned, and this is common in the previous project with the CTC providers, close to community, the ladies who were with us last time. So communities are used to be recipients because of the NGO mentality that is going on forever. And it's hard to shift between recipient and you are the actors. So they tell me, I collected this for you. This is not for me, this is for you. We're just here to moderate, to help, to support. So this is a main problem all over the place, not only in this project and in the other project. People are there as recipients. Tell us what to do. You have we co-develop together. So this is a main issue, and we are really facing this problem because people are, خلاص, NGO mentality. You come, you give us a project, yoga sessions, meditation, and we go, and then that's it. So we're building a structure here, and this is taking a lot of time.
Yeah, actually, they ask for money to do that, as if like you're a funder and they are I don't know, an NGO, so yeah.
I'm just gonna...
Yeah, maybe you have.
Actually, just to leave you with some positive vibes, I just need to tell you that I had the privilege to be with the ladies in one of the sessions, and I need to acknowledge the great efforts that they are putting, because to be very honest now, asking people to come to attend capacity building, strategic planning, and all these things in the middle of the financial, political instability and all those things is not an easy process. Well, thank God we have the municipality, and we all know that they are not getting paid. They don't have a fuel. Just for you to know that those ladies are giving training بطقس مفرز. We were freezing when we went there because they don't have the fuel. They cannot afford that. So I would say, inshallah, I would say that I can see there is a sustainability, because if people are coming now in this situation, they have this willingness to learn, to maybe change. I don't know, but maybe I'm a positive person, but I would say it like that. I forgot my second point. Excuse my pregnancy.
Thank you. I really do agree with many of these important points and challenges, because we feel it. The ownership, sustainability, mentality, all these issues. And we still have at least 2 more years in the life of this project. And we will put this as a sort of priority, of how to do so and how to be sure that in 2 issues. One, to improve the documentation, because I guess this is really an important issue. Documenting, Rouham mentioned, even we document the WhatsApp group, chat, because it's a sort of an official WhatsApp group.
Because here the process is the important thing. The outcome, we're not sure about it, and we're hoping to have this established. But the process is the findings. So that's why we are really documenting everything. Yeah.
The second issue is to see what's the right strategy for sustainability. And Rouham mentioned something about secretary. And luckily that the mayor, adopt this idea and, want to have this local coordinator as a part of the municipality. But we also know that this is also could be a challenge later, if something happened or the municipality.
Or the elections, the main problem was, whenever a new mayor will be elected, he will accept this committee. So our strong point would be that if you are a working group, any mayor would be really happy to work with you if you show him you are a working entity, because everyone is appointed. We know how they are appointed or elected. So we are counting on that to build a strong group, a strong structure that any mayor from any political party, because we have inclusiveness for all political parties and members. So we are counting on that to propose a strong structure that any mayor cannot refuse. So
And what could help if the Ministry of Public Health, adopt these initiatives. I mean, playing a major role in this. So if, I don't know, municipality change, they can take the initiative to other municipalities and so on. So that could be our ambition to do in this project. And hopefully, if we can succeed in doing so, maybe that will, mitigate all these, challenges and risk for the continuity of the project. Thank you.
طبيب القضاء الحجة كانت انه ما معه بنزين يجي من زحلة على مجد العنجر. لا انه قلنا بنروح لعنده لانه عملنا we did the first interview with him and of cycle we told him we will meet you in the office. He refused.
ما بيقدر مش انه بس ما بيقدر بس هو بده هو ما بيقدر لانه ما عنده بنزين وما عنده بس كمان ما بده.
Anyway, this is a challenge that we need to see how to deal with that.
Can I make one small comment? I don't know how much the faculty will be involved in this, because this is working opportunities for our students. يعني why do we look for
Dr. Shaya actually.
طبيب القدم.
Yeah. Anyway, so it's an opportunity.
Involve public health students, graduates. لا بس I'm thinking أنا عم فكر غير شكل، عم فكر يعني pushing for a public health. هلا فادي مثلا ما يقول هو حكيم as much as هو MPH و public health. ايه يعني this will create an image. يعني تصور إذا كل هالmunicipalities will need people to guide this health committee. يعني لازم Thank you.
Okay. So thank you so much, Dr. Fouad and Dr. Yamout, for sharing your experience. We wish you all the success in your project.